Well, I did not set out to write this book. So I initially went to Puerto Rico to study something very different. I was really interested in why the island has some of the highest cesarean section rates and some of the highest female sterilization rates in the world. So when I was in graduate school and getting ready to go do my 1.5 years of ethnographic study that you have to do as an anthropologist, I imagined that's what I would be working on. After a round of grant applications that unfortunately were not successful, I decided instead of spending another winter in Cambridge, I would go ahead and move to Puerto Rico and look for a job and try and get started while I applied for more grants to do this other project on women's health. I happened across a job at a Medicare Advantage company, which is this managed care way of receiving Medicare. So I heard about this through a friend, and I thought it would be a good way to kind of get on my feet, get acclimated, get settled, and start working on this other project I was interested in. Slowly, I realized something really interesting was happening in Medicare Advantage. So at the time when I moved to Puerto Rico, you couldn't drive down the highway without seeing 10 signs to join a Medicare Advantage plan. There were many new companies moving to the island, opening. There was a lot of advertising, a lot of coverage in the newspapers, and it was just this sort of explosion of interest in managed care. And so as a medical anthropologist, my curiosity was piqued. And so slowly I realized I was going to no longer be working on women's health, at least not for this particular project. And so I began to get very interested in what was happening with managed care. So why were all these companies moving to the island? What was happening there? How was a privatized form of receiving Medicare different from the way it had traditionally been delivered, and what was the impact on quality and patients' experiences? So those were some of the questions that I initially set out to answer. So Puerto Rico actually went through what I talk about as being two different waves of privatization. So the first one began in the mid-90s with the switch to a managed care model. So previously, healthcare in Puerto Rico was delivered through what was known as the regional healthcare system, where there were clinics in every town, and most of them had behavioral health together with a dispensary for pharmaceuticals. And so patients would go to their local clinic, they would receive care free of charge, there were no insurance cards, and for more complicated issues you would be referred either to the regional hospital or to the University Medical Center, which is located in the San Juan metro area. When that was privatized, what happened was people were enrolled in private managed care plans. And so they received an insurance card, they were assigned a primary care physician, and instead of accessing care through their local clinic, they went to the private system. Now, with part of the problem with this was that you had for the first time a group of people who were uninsured. So previously being uninsured didn't really exist because you could just go to your local clinic, nobody asked you for an insurance card. So you did have a creation of a group of people who were uninsured either because they didn't meet the income requirements or because they didn't go through the eligibility process. And then you also had other kinds of problems with people actually being able to access care. So care rationing, particularly by primary care physicians, became an issue when it came to getting referrals for specialty care or getting prescriptions, getting their prescription drugs that they needed. That came up again and again in my work, and also in the work of other researchers about the impacts of privatizing the public health system. Then later on in the 2000s, in the second wave that I talk about, that was when Medicare Advantage, or this privatized way of receiving Medicare services, really came full force to the island. And so with Medicare Advantage, beneficiaries receive their Medicare services through a private managed care firm rather than the traditional fee-for-service system where they would just go to a doctor who agreed to accept Medicare. So these private managed care firms receive what's called a capitation, so that's just the payment that they get per member per month to manage people's health, or to manage their health care. And one of the things that happened in Puerto Rico was that the rates that they were paid were extraordinarily high compared to the rates that were paid in the rest of the healthcare system on the island, which is one of the reasons why you saw this massive influx of companies in the mid-2000s trying to break into that market. One of the things that's different about my approach to this topic, so plenty of people are interested in health policy or privatization or Medicare, but I come to this as a medical anthropologist, and so my primary method is to conduct ethnography. Anthropologists do long-term, and for me that can mean a lot of different things. For me that means doing long-term participant observation, so I went to actually work at a managed care company. I worked in the compliance department, which is the area of the company that conducts both internal audits of all the departments at the company and was also audited by the federal government. It's also the department that received and processed member and provider complaints. So I had a lot of contact with regulators and also with some of the issues that were sort of bubbling to the top from the members who were running into problems. So I worked at this company for 2.5 years in the compliance department. And I also conducted interviews with members. So I went out to their homes and talked with them about their experiences using the healthcare system in its new privatized form. So some of them, many of the people who I talked to also received services under what was called La Reforma on the island, which was that sort of first wave of privatization I talked about. So as an anthropologist, I'm interested in how people experience reform rather than just the sort of rhetoric or rationale that's given for reform projects. So many of in both the Medicare system and with La Reforma, policymakers talked about how the new system would be more efficient, how it would have higher quality care, how people really wanted more choice. And I was interested in how is that actually playing out for people in their everyday lives as they're trying to access care. And some of the things that I found was, in fact, people were overwhelmed by choice, and often choices among things that were very similar. So when it came time to pick a plan, people may have 30, 40 plans to choose from, and they had a very difficult time distinguishing which plan made the most sense. And with good reason, the plans were actually quite similar when you looked at what they offered. So that's sort of one of the things as an anthropologist I'm interested in, right? How are policymakers explaining or justifying these kinds of programs, and then what are they actually able to accomplish when they touch down on the ground? One of the things I was surprised about was how passionate some of the people were at the company where I worked. So at this private managed care firm, many of my colleagues, I think in good faith, really felt like they were out to improve and modernize the healthcare system. They really understood that they were focusing on quality in a new way and making the system more efficient. And I think really believed in the work that they were doing. And so as an anthropologist who had been trained to be very critical of that kind of, of managed care in general, I found one of my central projects when writing the book was, how do I reconcile that? How do I make sense of the sort of moral mission that people were bringing to the work that they were doing? And that's why the idea that this was a moral project is one of the central things I talk about in the work. One of the things I'd like readers to take away is to be a little bit more critical of some of the language and jargon that we tend to use in healthcare. So some of my chapters take on words like quality, choice, partnering. And I think it's really important for us to think through what we mean by those terms and to think about how multiple constituencies might imagine them differently. So one of the things I talk about in my book is that what quality healthcare means, right? That seems like something we could all get behind. We all want high quality care. But when you actually look at what quality measurement means at a health insurance company versus what it means to government regulators versus what it means to elderly Medicare beneficiaries who are trying to get their needs met on the ground, it can be radically different things. So I hope the kind of long-term research that I do really helps point to those very different understandings that are operating across groups, even though they might all be called quality.